Well, welcome everyone who's joining us from a distance today. We're about to get started with our Making the Case for Nutrition Screening in Team-Based Primary Care. Just a couple of housekeeping items before we jump into things. So for those of you who don't know, my name is Lee Kapuscinski. I'm the previous Vice Chair of the Dietitians of Canada Family Health Team Network. And this webinar is part of a program that we started to help with knowledge translation across the province for some of our family health teams and interprofessional colleagues who come to us from a distance. As always, the session today will be recorded, and we can let you know the location of that recording at a later date. I'm thinking likely through the AFTO website, but we will be sending details around that to you after today's webinar. We do have a section for questions. So on the GoToWebinar control panel, there's a questions tab there. And so at any point through the presentation, please feel free to type in your question there, and we will be holding them until the end of the session for a Q&A period. So we are so very fortunate to have Dr. Heather Keller with us today. Heather is a RD PhD, and she is the Schlegel Research Chair in Nutrition and Aging at the University of Waterloo. Research programs across the continuum of care and are focused on improving the nutritional status and food intake of older adults. Her acute care program of research is focused on improving food quality and nutrition care process to prevent, detect, and treat malnutrition. Her current projects include Phase 2 of More to Eat and the Hospital Patient Food Satisfaction Study. Research in residential and long-term care is focused on improving the nutritional and sensory quality of food, as well as enhancing the mealtime experience for residents, family members, and staff. Community-based research includes nutrition care processes and improving food intake of vulnerable older adults, including those living with dementia and/or frailty. Professor Keller has led several national research and knowledge translation projects, including the landmark Nutrition Care in Canadian Hospitals, More to Eat, and Making the Most of Mealtimes in Long-Term Care Studies. Professor Keller has published widely and translates research into practice with practitioner tools and resources. As a founding member and past chair and co-chair, 2009 to 2018, of the Canadian Malnutrition Task Force, she is involved in translating research into practice and advocating for improvements in nutrition care. Please join me in welcoming Heather. Thank you.
Thanks very much, Lee. So it's a pleasure to be speaking with you about an area that I've been working in for many, many years and getting back into now that some of the foundational hospital work that demonstrates the importance of community care in nutrition has come out. And so I wanted to bring this to this group to encourage you to get involved in key aspects of care that can support older adults and all the other vulnerable groups with respect to nutrition. So my title is Making the Case for Nutrition Screening in Team-Based Primary Care, with the idea of specifically trying to meet the needs of frail older adults. So I want to first start off with a few definitions to make sure we're on the same page with respect to what we're talking about. So malnutrition can be defined or is defined by us in Canadian Malnutrition Task Force as the inadequate intake of energy, protein, and/or micronutrients. The key with why it's malnutrition and not just poor food intake is it actually leads to functional change in the body, whether that's weight loss, muscle loss, weakness, immune function changes, etc. And so for something to be considered malnutrition, that poor intake over a period of time, it has to result in that functional change. Why it's different from other conditions like cachexia, for example, or potentially even sarcopenia that might be based in physical activity and hormonal changes is that it responds to feeding. When someone is fed, they improve in terms of both nutritional status and the functional parameters that are indicating that there was malnutrition in the first place. A key point for all of us, though, and something we've learned over the last 20 or so years, is that inflammation, and we're having a greater appreciation for what that is and how it impacts our health overall. It affects the response to that refeeding. And so someone in hospital, for example, who has anorexia because of cachexia, it'll be more challenging to refeed that patient because they also have the inflammation that's going on. And so those are the challenges when we try to treat malnutrition, when there is severe inflammation present. So what is malnutrition or nutrition risk, depending on how you call it and maybe what setting you think about? This is essentially the presence of risk factors that we know impair food intake or affect nutrient utilization by the body. So it's typically seen as low or poor food intake. It also occurs before you start to see the overt signs or functional changes of malnutrition, like weight loss. It's obviously easier to improve and reverse than malnutrition, and it's commonly measured by looking at a variety of determinants of food intake as well as other risk factors, and sometimes reports of self-reports of weight change. I created this diagram here to try to show you sort of the way we can think about malnutrition and undernutrition risk, or nutrition risk, or malnutrition risk, if you want to call it that. And also how some of the tools that you may have heard about, how they sort of fit into this process. And so if we think about the far right-hand side, where undernourishment is there, that's when we know someone is not meeting the requirements through either consuming enough food or the way their body's using the nutrients is out of whack because of inflammation and excess of metabolic needs. But you see this change in function, loss of weight, adverse health events, etc. And inflammation is usually largely involved at that point as well because of disease states that might be part of the process. There we typically want to do assessment, right, to diagnose that they truly do have malnutrition. And so we use dietitians with their clinical judgment or something called subjective global assessment as a way of diagnosing malnutrition. Before that, before someone actually has those functional changes, we call that nutrition risk or malnutrition risk. And you can think of tools that are very upstream, so where they're more looking at the determinants and risk factors of food intake, or closer to the actual end stage of malnutrition. And so some of those changes, or some of those tools, for example, they're upstream would be screen tool, which we'll talk about today in more detail, as well as downstream, the M&A, the CNST tool, which is used in acute care hospitals, 2 questions focused in on significant weight change and appetite change for older adults and others. So this is just to give you a sense of how this could fit together. And so when we're talking about different tools, you need to realize they measure different things. And nutrition risk is going to be something that we see more of, obviously, in primary care than malnutrition. The other key aspect of this talk today is about frailty. And there's 2 key ways that people think about or define frailty, and I've got them here on this slide. One is the phenotype model, and the other is the cumulative deficit model. Phenotype is based on 6 criteria that are listed there, and if someone has 3 of those, they're considered to be frail. And malnutrition can obviously be seen in this one because of the idea of weight loss as part of the criteria. The cumulative deficit model is focused on an accumulation of deficits, which can include things like poor vision, more medications, having an infection, so a variety of deficits that just accumulate to the point that it actually overburdens the person and they become frail. And so frailty, as you likely know, has become a very hot topic in research and in practice. There's a lot of work looking at how best to diagnose it, and we're starting to see research focused in on how to treat it and prevent it as well. And so we'll be talking about some of those aspects today around prevention. Pre-frail older adults, Canadian Frailty Network is a National Centre of Excellence that's specifically focused in on targeting and developing research and expertise in Canada with respect to frailty. And they defined frailty here for you as noticeable losses in a person's physical, mental, and social functioning. And they estimate to be about 1 million seniors at this point in time in Canada, and with the prevalence likely doubling in the next 20 years. This is a significant problem. And for those of you in primary care who may not think of frailty per se, you might think of your high needs patients, for example. Those are the frail folks we're talking about. But there's pre-frailty as well that often is missed in the primary care sector. And we certainly need to start thinking more upstream about these folks as well and coordinating our care to meet the needs of these older adults who could be frail. Research to date has also demonstrated there's a significant overlap between malnutrition and frailty. More and more papers, my student and I, Celia Lohr, wrote this paper in 2017 focusing on the overlap between malnutrition and frailty, and in the last year there's been several more papers talking about this idea that malnutrition and frailty often coincide. And so just to give you a sense, they have similar symptoms in terms of weight loss, exhaustion, weakness, also common risk factors like physical changes to the body that impact then the person's ability to do things and leads to weakness, but also impacts their food accessibility. There's a definite overlap in prevalence that's been noted. And we expect that when people are frail and malnourished together, that they actually have a much more challenging trajectory with respect to their care and with respect to the outcomes that we see with them. And so it's a significant condition that we want to try to intervene as early as we can in terms of addressing both frailty and malnutrition. So now that I've given you a bit of that background, I want to get us start to think about, is malnutrition risk really a problem that you should be dealing with in primary care? And Celia and I wrote a paper in I think 2017 as well, talking about making the case for screening in community care. And I refer you to that paper as well to get some more detail after this presentation. But this is the notion I'm working with, and hopefully I'll demonstrate to you by the end of our time together that definitely screening and identifying nutrition risk and malnutrition in your primary care setting is an important area of practice that we need to be all doing. I'm going to focus first on the prevalence of malnutrition, its risk, and outcomes to show you the importance of this issue. The Canadian Malnutrition Task Force between 2010 and 2013 did a landmark study looking at 18 hospitals in Canada and over 1,000 patients. And we were looking at what was the prevalence of malnutrition when we used a diagnostic framework, the Subjective Global Assessment, that would be standardized and could be then looked at in terms of comparing hospital sites and patient populations and controlling for many of the factors that people think are related to malnutrition, but often will say, well, that's what's causing the problem here. It's not malnutrition itself. We wanted to do a much more rigorous study than had been done to date, and that's what this study was. And we basically identified that 45% of people coming into a medical or surgical bed and staying 2 or more days in that hospital bed was malnourished, either moderately or severely malnourished. That's the orange and the gray on the left-hand side of the slide here. 3/4 of the people that came in that condition were not identified by the hospital staff. And so that's been much of the work we've been doing at the CMTF over the last 5 or so years with the More to Eat project, phase 1 and phase 2, trying to change that process of care. I won't be speaking more about that today. But what I do want to talk a little bit about as well is the outcomes, which you see on the right-hand side of this slide. In that Nutrition Care in Canadian Hospital study, we demonstrated that malnutrition alone, when we control for disease state, age, gender, other conditions that might be impacting the person, like number of medications, for example, if they had a surgery or not, those sorts of things, when we controlled for them, being malnourished on admission additionally led to 3 more days of hospital stay, which we estimate to be about $2 billion per year for the acute care system in Canada, which is a significant cost. So that tells us that we have to do something around this issue of malnutrition, both identifying it in the hospital setting and treating it there, but also where it starts. So the people that came into hospital, we had looked at some basic demographic and health characteristics of these folks. And you can see here on the slide, the people that were malnourished on admission were older and more likely to have an adult child doing the groceries for them and had greater comorbidity. Those 3 factors are significantly associated with the being malnourished on admission when we did a regression analysis. So this is essentially those frail folks that we're talking about that have some deficits and are having challenges with respect to basically living the way they want to in the community. So malnutrition that we see in the hospital really starts in the community. So why does it start in the community, especially for older adults? And so we know for a long period of time, these characteristics are associated with poor food intake and malnutrition in older adults. This is not new, but we're still not necessarily doing what we need to do, which is screening and identifying those folks. If we look at the Canadian Community Health Survey from 2008, you can see the prevalence of some of these challenges or barriers to food intake, quite substantial for older adults. So it's not surprising then when we look at the prevalence of nutrition risk in the community that it is quite high. So back to the hospital malnutrition just for a moment. In addition to looking at what happened to people in the hospital and how it impacted their length of stay and other outcomes, we did a follow-up survey with folks to find out what happened to them. Were they being readmitted? Did they see a dietitian, etc.? We found at the end of their stay, for those that stayed more than 7 days, we actually looked at their nutritional status, again, using subject global assessment, and found that 20% deteriorated during the hospital stay, but they successfully left the hospital. And what we found was that weakness in hospitals is associated with poor food intake as well during the hospital stay. So back to that notion that nutrition risk, malnutrition, and frailty coexist. And if they're not picked up on admission and interventions put into place in terms of better access to a tray or nutrition supplementation, that patient will deteriorate further and they go back home in a more malnourished state and frail state. In addition to that, we did the 30-day follow-up, as I said, and between 19 and 26% had weight loss post-discharge. The 19% actually comes from a subsequent study, the More to Eat study, where we did a similar 30-day follow-up with folks across 5 hospitals and found that, again, a good portion were losing weight, reporting that weight loss after discharge. However, most of those people had seen a physician in that 30 days in their primary care setting. And despite that, though, relatively few saw a dietitian. So this is the challenge we have. People are getting back into the primary care system after hospitalization, but the challenges they're having with respect to poor appetite, weight loss, etc., are not being picked up. And we also know from that study that 20% are readmitted, and weakness in terms of hand grip strength measurement predicted that readmission to hospital. So hospitals perpetuate malnutrition and frailty, and so for your patients that are moving back to home after being in hospital, there's a good chance that they're going to be malnourished. And I'm sorry if you hear some of the background noise. We're doing some construction at the building I'm at right now, so let me know if it gets to be too bad and I can use the handset instead. With respect to community now, let's switching gears, look at the prevalence of nutrition risk. We don't have prevalence of malnutrition. It's much harder to get that, as you can imagine, with doing a subjective assessment in primary care or other settings. But we do have nutrition risk through looking at questionnaires, typically. And this is using one questionnaire that we'll talk a little bit about later, called SCREEN. It was used in the Canadian Community Health Survey, and 34% of people were found to be at risk. And those folks, about 1 million of them, tended to be women, people over the age of 70, low income, etc. So that frail or high needs group that we've been talking about. What happens to them? So 3 to 5 years later, they did a follow-up study, and they identified, 2 to 3 years after they did a follow-up study, identified that those people who were at nutrition risk when they controlled for other key covariates, people are more likely to be hospitalized or die. So this nutrition risk, even crudely estimated with a questionnaire, not doing objective measurements and a subjective assessment, predicted those outcomes. So again, we need to be then looking for nutrition risk in the community and intervening properly. A subsequent study that I've just got submitted with one of my students looked at a much larger data set using the same SCREEN tool, but you can see the prevalence is very consistent here. And in that data set identified as well that health outcomes such as hospitalization, emergency room admission, self-reported poor health, low satisfaction with health were also associated with that nutrition risk. If that hasn't convinced you, there's quite a bit of research to show that beyond hospitalization and mortality, other outcomes that we are often concerned about and count or try to prevent are also associated with poor food intake or nutrition risk with older adults. So lots of evidence to say this is an important problem that we need to be doing something about. So if I've just switched it to thinking now, I hopefully have shown you that prevalence is high and it's worthy of attention in terms of its importance to the health and care of older adults and their quality of life. Can we think about upstream? Is there potential that we could even prevent this frailty Or is it a foregone conclusion that this is going to happen when people have accumulation of these risk factors? So there's this concept of inflammaging, this idea that inflammation is a large part of the aging process that we see that can then speed up the process of frailty and lead to these challenges that we see with these patients that are high needs. The diet is one of our best sources of antioxidants, and that might be a way of intervening. If we look at the literature around Mediterranean diet, which is typically a high vegetable and fruit diet, low in saturated fat and refined grains, it's very high in antioxidants, and there's many studies now demonstrating that it's associated with prevention of frailty as well as other outcomes. This idea of a high-quality diet that can meet the needs of a person in terms of their nutritional requirements is what we need to be promoting. So there is that evidence that perhaps if people are eating better longer, we can prevent and delay frailty as well as malnutrition. In addition to the idea of inflammation is the idea of protein. We know, again, about a decade's worth of work and even beyond, higher intakes of protein are associated with better muscle status, better function, decreased mobility limitation, and disability in older adults. And so quite a bit of research has been done in this area, and some of it looks at, the timing of it and how much, but the key is always more protein is better in these folks. Of interest, I ran across this study recently that just came out this year that many older adults who think they're quite healthy and doing fine, in this study they looked at physically active older adults, and they found that 2/3 of them did not meet a recommendation of 1.2 grams per kilogram per day for protein. And the suggestion was made that these folks may not benefit as much as they think from the physical activity they are taking part in because their diet is not sufficiently high in protein. So there's those people out there that we know that are trying to stay healthy, but they may not realize they're not eating enough protein to maintain that muscle and other health benefits as a result of that. So hopefully I've given you a sense it's truly important to be looking at nutrition risk and malnutrition in primary care. Many of your patients probably have nutrition risk, and we need to be doing something about it. But you're probably asking as well, is it treatable? The dietitian's on the line. No, it's definitely treatable. But for those of you that are not dietitians on the line, you might be wondering, well, can we do anything about this? Does it change what happens to folks? And the answer is yes, it absolutely does. There's quite a bit of evidence. I've just located here 2 very large reviews that looked at using oral nutrition supplements in whatever context it may be, whether it be hospital, long-term care, or community, and that's been demonstrated to promote nutritional health as well as improved health outcomes. In addition to that, when we pair a dietitian with either alone or with oral nutrition supplements, a similar review demonstrated benefits in terms of increased body weight for folks. So there is a benefit, and we can treat. And many of these studies that were involved in these reviews were malnourished patients who are quite frail. So we can intervene and make improvements. The challenges, and I get this from work from some colleagues that are part of the primary care and AFTO, most of the RD time, though, in family health care or family health teams and community health centers is spent on chronic disease management. It's not spent on these pre-frail nutrition risk patients. And so this is a thing that we have to be changing our mindset about. We have to rethink what we're doing in primary care and think about prevention as well of frailty and malnutrition. In addition to a dietitian, there's other evidence, because I've heard this often from folks who work in practice outside of Ontario where they don't have access to a dietitian and family health teams. Well, what can we do? There's no dietitian service that we can refer someone to. There are other things we can do for sure. Meal programs, social programs, health education series, and transportation services. All of those things, thinking about the determinants of why people are not eating well in the community. If we can influence those determinants, we can influence the nutrition risk and the eventual frailty. And there's evidence as well about these. So for example, Meals on Wheels have been shown to reduce patient emergency room visits and admissions. Telecounseling by a nurse improved malnutrition risk and food intake. And education sessions improve malnutrition risk. So there's definitely things we can do when we don't have individualized counseling within a family health team or community health center like we do in Ontario to impact nutrition. In addition, over the last 5 or so years, there's been a real impetus to start thinking prevention with older adults in the community, recognizing this large and growing group of folks living in the community becoming more and more vulnerable, and that putting stress on our healthcare system. And they certainly don't want to also be moving into long-term care anytime before they have to. So the Living Longer, Living Well from Ontario, the McMaster Health Forum that was done in 2015 looking at nutrition in the community, State of the Nation, which is a UK group that looked at the BAPN and others in UK, talking about the need to look at malnutrition and care in the community, and then finally the World Health Report on Aging. All of these point to nutrition and a quality diet as a key aspect of prevention for older adults in terms of their health outcomes. So it's time for us to be moving forward. This recent publication just came out, I believe, in October of this year from Sinan Group in Toronto, the Canadian, and they call it the Canadian Consensus on Frailty. You can see the prevalence there of frailty increases with age, obviously, but they also identified that what you eat is a key part of this puzzle, and we need to be improving our care, whether it be through individuals' nutrition counseling or looking at the social determinants of why older adults eat the way they do to prevent this frailty. So I contend that nutritional status of patients impacts quality of life, mortality, morbidity, and transitions in care. And so that means all sectors need to be involved in detecting and treating malnutrition. And this is the paper that I spoke of earlier that Celia Laura and I wrote last year, making the case for nutrition screening in primary care. So in Ontario, we're now moving swiftly ahead with getting screening done in hospitals on admission. And certainly long-term care with dietitians already in service there, they're doing the job of identifying those people that have malnutrition and treating that. Primary care is where we need to make headway. So it's about case finding. It's about finding those individuals who could benefit and from nutrition risk screening, as well as the next steps with respect to care. I'm going to make some general points about screening and show you the screen tool specifically, as it will give you an idea of some of the things you might be thinking about with respect to treatment afterwards as well. But key is that we need to be using a valid tool that's designed for community sector. It's got to be easy to do. No matter what the healthcare sector is, more data collection and more assessments of patients is never desired. It has to be as easy as possible. And so there's things that are happening within the healthcare environment, and specifically in family health teams, such as using tablets with the actual patient or client as a way to facilitate that screening. Also, you'd want to typically use tools that don't require measurements, because as soon as you have to do a measurement, it's going to take time of staff to do that. That staff has to be trained. And you also have to plan for how you're going to address the risk. Even in the hospital sector, we have to do that. The reality, though, is it's a little bit harder in primary care because a patient comes for a few minutes to visit and then they go back home. So it's really about planning around that person in the community, how those needs can be met. Unlike in hospital, you have them for a set amount of time, and you can facilitate a variety of assessments and treatments in that setting, and then hopefully carry them over when they go back home. Powers put out a systematic review this year talking about nutrition screening in older adults specifically and in the community. And they identified there's actually only 2 tools that are designed for this setting. They were designed because they are appropriate for the setting because they were actually designed and tested in the community sector. So other tools that are out there haven't gone through that validation testing. That doesn't mean they might not be appropriate, but they haven't gone through the validation testing yet. The 2 tools are SCREEN, and it stands for Seniors and Community Risk Evaluation for Eating and Nutrition, a tool that I created almost 20 years ago, I guess now, and then the Mini Nutritional Assessment. And this is just a quick comparison of the 2 tools on this slide, as well as how you can find out more about both of them. So the full versions are similar length. The shorter versions are also similar length. Screen does not require any anthropometric measures, whereas the main nutritional assessment does, either body mass index or calf circumference. Screen is available in Ontario anyway on ocean tablets. And a difference between Screen and the M&A is that the way that the questions are structured actually helps you to identify what the needs are of a client or patient with respect to care. And so it can be helpful then, especially in teams that might not have access to a dietitian, to identify what are those community services that can be put into place for an individual. So just to show you the items on screen, you can see them here. You can see that many of them are upstream. We ask the person to report on weight change. It can be loss or gain, as well as their perception of their weight and their intentionality of weight change. This is because we know that people are trying to lose weight as they are older. They often will do it through diet only and get into challenges with respect to a quality diet then. The starred items are those that are actually on the abbreviated 8-item version. And just to show you, this is what a question would look like. And again, this is unique. The other tools are typically yes, no. Screen can help you see if a person's improving or getting worse. And so it has advantage for evaluating the treatment plan that you put into place as a result. So just some current work on screening that's been done in Ontario. And again, thank you to my colleagues who passed along this information for me, which is very helpful. There's the four-center quality improvement study that's being done, located, the main site is in Hamilton. So the Hamilton, Niagara, Upper Grand, and Sudbury Family Health teams, they've been basically putting Screen, the tool that we just talked about, into place to look at the prevalence of nutrition risk, as well as looking at the feasibility of a team-based approach. And they're still implementing that, and we'll have, I'm sure, results soon about that. But outside of that QI study, the group has, at AFTO, the primary care group that's involved in looking at nutrition care in the community, has been putting together resources, and 85 family health teams and CHCs are actually involved in screening at this point in time in Ontario. So that's great progress, and hoping to get it to a much higher group by next year and beyond. Just to highlight on the right-hand side here, McMaster Family Health Team has a Healthy Aging series as a way of addressing the nutrition risk of people that they identify. So they don't always get funneled to see a dietitian. They have other ways of meeting that nutrition risk. And they had received a Bright Lights Award because of this program, where they do exercise as well as nutrition education in a group format. So there's many ways to deal with the risk. It isn't always just individualized care. Back to the case finding approach. It makes most sense to start with a targeted group of people to identify their nutrition risk. And so these are some groups that I've thought of, and others as well, that might be a way to target or segment your primary care clients to identify who should actually go through nutrition risk screening. So for example, you can identify those that are 75 years in age or over. If you go back a few slides to the Center report, you can see the prevalence jumping as soon as someone moves over the age of 75 to be frail, with 1 in 2 being frail by the time they reach 85 years of age. And so that might be a group to start with. Another group you might start with is if you are doing frailty screening, and Dr. Linda Lee came out with a paper, I think last year, saying that hand grip strength and 5-meter walk would be easily done ways of screening for frailty in a primary care setting. If you're doing that already, that again would be a population, if they identify to be at risk, to then do nutrition risk screening. Those who screen as pre-frail, if you're doing some other sort of frailty assessment. Those who've been recently hospitalized, based on the data I showed you from the Nutrition Canadian Care Hospital study. Home care clients, they're obviously already high needs clients. They may not be getting sufficient services through home care to meet their needs. And then finally, a recent paper that just came out talked about even people saying that they don't perceive their health to be very good, they perceive it to be poor. Those folks are probably at risk for a variety of conditions, including malnutrition. And so just one quick question to identify, this might be a person that we need to put through more assessment in terms of both frailty and malnutrition risk. So putting screening into place. I had the pleasure of Celia Lore as a doctoral student for several years, and she's just finishing up now. But her last part of her thesis was looking at a family health team project in the Northeast Lynn, where they were trying to implement nutrition risk screening, use the screening tool. These 6 locations had previously been involved with a fall screening program that had been conducted, a pilot, and it was carrying on with that task, but adding to it the nutrition risk screening tool, and specifically Screen 2, the abbreviated version of 8 items. To make this a feasible model, in addition to putting the screen tool on tablets, we created, I shouldn't say we, the family health teams up there and the great group that they had created individualized messages that could be printed out for a patient based on their nutrition risk. So a handout that was individualized immediately would help a client regardless of their consenting to go on to see a dietitian or go to another program to meet some of that risk. She did a qualitative evaluation with 31 individuals. 7 of those were clients, so older adults who'd gone through the falls in nutrition risk screening. And some of the key things she identified are on the slide. I didn't want to put any quotes at this point because it's not published yet, but key for building the screening program were these 4 things. First, you have to set up for successful screening. You have to think about building that awareness and importance for why we should be even looking for malnutrition in a primary care setting in specific groups, such as those over the age of 75. Key was seeing that this could benefit clients. You don't want to put screening in place just to collect data. It actually has to do something. And people want information, they want education, they want to know what resources they can access to promote improved food intake. So you need to see it as benefiting clients. It's not data collection for just the essence of doing that. Tablets really made it easier to do screening in those settings. Key as well for setting up for success was actually planning and thinking about what could be the offshoots in terms of treatment for those patients after they were identified to be at risk. And the idea that there's so many people creating resources that we need to start sharing them and making it easy to do that so that people don't have to reinvent the wheel with a document or with an educational resource. In addition to successfully setting up for successful screening was the idea that every family health team is different, and even satellite sites within family health teams are different. So you really can't just do a cookie-cutter approach to this. You have to think through how the process could work in that specific setting, what team members might be involved, how risk would be communicated and by whom, and what would happen afterwards. So it really does take that bit of work at the front end to think through the process clearly and realize it might take some tweaking over time as well. Key was the idea of following up with risk. The family health teams, when they had created the pilot for screening for falls, a key part of that led to new falls programs, and those were delivered by public health, for example. But many of the sites identified there weren't the same sorts of community programs, especially in that region of Ontario, to meet the needs of risk. So it really identified we have to figure out how to follow up with risk beyond just the education of the individualized key messages for these folks. And then finally, it's really about building relationships. They talked about the need to build relationships within the team within that family health team, but also outside of the family health team, and think about the community as a whole and how it can work together to meet the needs of these individuals who are pre-frail and potentially malnourished as well. So how to start? For those that are MDs and nurse practitioners online, I'm hoping that this presentation has convinced you that malnutrition is something that is affecting your patients. And you as leaders in the organization need to lead your teams to recognize that this is a serious issue that we can treat, but we need to put into place processes of care to change what we're doing now. So identifying who we will screen, what services and programs that are already available or can be made available, and using that data to also develop new programs. I was at the Family Physician Forum last week, and someone from BC said she loved the notion of doing screening in primary care, but had no access to dietitians in their community. I said, well, you know, most communities will have some sort of community program for older adults that might be involved in food, might be involved in a meal provision, for example. And so finding those and sussing them out. And if you don't have them, collecting that data in your primary care office to demonstrate this is a need, and rallying the municipality and the county to think about how can we support older adults in this way. And so that data can support you in that process of developing some of those programs. So what could the process look like? Screening, think about what is the tool you'll be using. We talked about a valid and reliable tool you'd want to use. Think about the target group they're going to try to case find within. And think about who's going to be administering it if it's not going to be on a tablet. So how is the screen actually going to happen for you, that screening process? Post-screening, how is the communication results going to happen? The provision of education materials and the recommendation for services. And then finally, the charting and follow-up for patients as well. How's it going to be documented and how's it going to be followed up? Not surprising, in Celia's project with the family health teams in Northeast Lynn, many clients said, well, we don't really necessarily want to see a dietitian as a way to address it. We don't feel like we're ready for that. So we need to think about in our follow-up process how we can reopen the conversation for older adults when they may have refused referral to a dietitian. This was something I saw as well when I did a study about almost 20 years ago called Bring a Nutrition Screen to Seniors Across Canada. Same idea that many older adults don't feel they're ready for that individualized step of counseling. One, they don't know what a dietitian does, first off. And then secondly, it might be seen as too high of a time commitment. And then third, for those very frail people, coming into another doctor's office visit is a challenge. So thinking through why that resistance is there around not seeing a dietitian is important to making sure that we follow up, try to resolve those issues, and meet the needs in a different way. So key for the post-screening is think about what's available inside as well as outside your family health team or community health center. So some supports to move forward. The Primary Health Care Action Group from Dietitians of Canada is focusing on Ontario specifically, has a toolkit which is located on a Dropbox right now, and currently 160 dietitians members access that toolkit for a variety of tools. That group is also involved in advocacy. They've done lots of presentations and through that have trained 250 or more people with this notion of doing nutrition screening and assessment in the primary care sector to meet this need. In addition to that group, the CMTF, Canadian Malnutrition Task Force, which is national, has a web page that we have developed and use as knowledge translation as well as resource outreach for folks that need it. It's been focused predominantly on acute care, but we have, as of this year, recognized, because of the data we collected, recognized the importance of primary care and have developed a working group specifically to start moving in this area. So look to that website in the near future to see resources and tools that could be used as well. We are also involved in CMTF in raising awareness around nutrition risk and malnutrition across the continuum of care, involved in developing tools as well as aggregating those tools and doing research. And so hopefully we're starting to do some research in the primary care space as well with respect to nutrition risk and malnutrition. So in summary, we've got some time for questions, which is wonderful. I hope I've convinced you that malnutrition or its risk is common in older adults. It's an important health problem, and it coincides with frailty. I also hopefully have shown you that poor quality diet can lead to frailty, and so if we can work upstream, we can have a significant effect. Improved food intake improves nutritional status and frailty. We have to get treatment to people, though. That's the challenge. Treatments are available, and they can be as basic as getting groceries into someone's home. Case finding through screening is a viable model, and it's being done already by many family health teams and community health centers in Ontario. So we do have models and resources to share, and more will come as we continue to expand this area. However, everybody needs to be involved in that nutrition screening. So I'm hoping for those family health teams and community health centers that are not screening now, some of those targeted groups, to start thinking about that and how can they build something similar to their colleagues in other family health teams to move ahead and improve their practice and make it a standard of practice in primary health care. So we can do better, and I hope that we'll have a fruitful discussion now for the next few minutes around this issue. Thanks very much.
Oh, Thanks so much, Heather. We really appreciate all of the evidence that you've been able to present to us today, and you've given us a lot to think about in terms of how to start putting some of this work into practice. So we have had a couple of questions come through. The first one is, what are your thoughts on adding, I believe it's referring to the CNST question, to a 7-day post-discharge questionnaire for high-risk clients? And the second piece of that is, would that CNST questionnaire not be valid for family health team use, and would it be best to use the screen or mini nutrition assessment instead?
Yeah, good question. So a person that's 7 days out of hospital is more like a hospital patient probably than a community patient. Maybe we can argue that, but regardless, the CNST has not been validated for either of those populations. So at this point in time, I would not encourage it being used until it's validated. I've actually put in a research grant to do exactly that, in addition to looking at screen and M&A, as well as subject global assessment in some key population groups that haven't been looked at yet in the primary care sector. And hopefully that will get funded, and we'll answer that question then. Is it sufficient? But right now, we don't know that answer. So I would suggest that you think about doing the abbreviated version of screen, for example, at the within the 7 days of admission of a hospital stay, and then either the short version or the 14 version in a primary care setting. Reason being, it's going to help you actually identify what you need to do. So imagine it's a nurse that's doing that 7-day screening. If you just ask the person how they've been eating in the last week, and if they've lost weight, you're going to get yes to both of those, right? Potentially quite high, but you're not necessarily sure what to do. But if you did screen, you might identify they actually have problems getting groceries in their home. This is maybe what I need to be doing. So it might change the treatment pathway that you have because you're doing something a little bit more in depth and looking at the risk factors in that setting in the primary care community.
Very good. Thank you. The next question reads, I know your presentation is focused on older adults today, but I'm wondering if you have come across research that has explored malnutrition in persons who have previously undergone bariatric surgery. Is there a higher risk for older adults post-bariatric surgery?
That's a really good question. And I don't think I've seen any research to date on that. I suspect there is some risk, though, right? Especially if they've had an older procedure that affected the absorption of nutrients, and they could be at high risk. And also, in addition, some of the changes that happen to their food patterns because of that risk. It'd be interesting to see if screen would be appropriate for that group in terms of their consumption. I don't know of any tool that's specific to that group. And because they're very unique needs, it might need to be something different. For example, a very small volume of feeding or eating, right, might be part of the reason why they might be at nutrition risk. So that's an interesting question. I don't know of a specific tool, and I don't know of specific research looking at malnutrition per se in older adults with bariatric or any bariatric action in the community.
Okay. Could a doctor or nurse practitioner administer Screen 2 or M&A, or does it have to be a registered dietitian?
It should not be a registered dietitian. It doesn't have to be an MD or NP either. It can be the receptionist, quite frankly, who could do screen. M&A is different. So M&A requires someone to either do a calf circumference or a height and weight measurement. So whoever the team member is that would have that skill set would be the person that would do it. So again, it wouldn't have to be an MD. It could be the intake nurse that could do that, or other personnel who feel comfortable. Screening should not be done by the dietitian, quite frankly. Screening is meant to be done by a personnel that's going to see every patient, right? And dietitian won't see every patient, so it shouldn't be done by the dietitian.
Okay. Are there any outcomes reportable from 4 Ontario QI pilots? If so, could you share?
I don't have those outcomes, and Michelle would be the best person. Michelle McDonald would be the best person to ask that of. Yeah.
Okay, very good. When screening is done from tablets in waiting rooms, is the score shown to the client immediately? Who is responsible to determine and advise a client to make referral to RD there and then?
Yeah, and so in the family health teams that we looked at in the Northeast, and they came up with their own models. Sometimes it was the the result was given to the patient that they were at risk, and then they had options to do something with it. It might have been a nurse who did that with them or another personnel who was seeing them. Sometimes they weren't told the answer, and the risk assessment went right to the dietitian, and then there was a follow-up call. So it really depends on your model that you want to do. I'm not sure if they actually told them the score or not. I'd have to go back to the data to see if that's how they did it and talk to Celia about how they actually did that process step. There's different ways we could imagine it being done. For example, the Nutri-East screen actually has the 14 questions for the screen tool on it, and we don't use the word risk for a reason, because we don't want to alarm folks. Sorry about the banging. I'm sure you can hear it now above me in my building. But we use the words where you're doing well and where you can improve. And that might be the language that can be used for folks when saying, we identified some nutrition problems rather than using the word risk. In other cases, you might want to use that word risk. Maybe that will stimulate people to change their behavior and come to see a dietitian, or realize the importance of what has been done, and then lead them to thinking about making some improvements. So I think we need to do a little bit more work around that whole piece on how the client perceives it and how it can be done in different models that could work.
Very good. We have a couple more questions here. Could malnutrition be seen as a chronic disease, and would this help gain momentum with awareness of malnutrition as an issue, and ideally implementing routine screening as standard practice for providers, for example, physicians and nurse practitioners?
That's an interesting notion. Makes me think we have to play games to get the issue put in front of people. I'm not sure I'd call it chronic disease. We don't consider malnutrition a disease, first off. We consider it a syndrome rather than a disease state. And it's reversible, right? Unlike other disease states, if you got diabetes, perhaps, well, I guess diabetes in some cases might be, if it's very early end, we might be able to get people back to normal glycemic control. But I would hesitate to call it a disease, first off. And chronic, potentially it's there chronically for folks. I'm not sure that's the model I'd want to move forward with. I think thinking more along the idea of prevention and screening around prevention for key syndromes would be the approach that I would think would be more beneficial. Maybe I'm wrong. Maybe we'll move forward with a chronic disease mentality, and that will actually change things faster. I'm not sure.
Okay. Do you know of any supports available for older adults who do not qualify for special diet allowance? I.e., we see a patient with diabetes who is over 65 years old, food insecure, blind, and frail, and was told does not qualify for special diet allowance.
Yeah, I don't. And this is a huge gap, right, with respect to food access and food security of folks. And we need to do a better job of documenting that and raising that issue. I don't know of any other availability outside of food banks and other social services that are available in communities, and they're often very unique, unfortunately.
Mm-hmm. And just one more question here. So while CNST may not be validated in primary care, for those sites without benefit of a tablet for applying a validated tool efficiently, as well as may have low RD allocation, how realistic has it been in practice to consistently apply Screen AB or other target group or other target groups? Yeah.
So I don't know the absolute answer to that, but I can tell you that Screen has been available for 15 years. We've only had tablets in the last few years. And people were using it in various community sectors in a paper pencil format. So people have been using it that way. Some have also thought to use the Nutri-East screen, so putting a desktop up in a lobby or in a reception area and having older adults fill in using a desktop, the Nutri-East screen, because it's already there and used, and printing it out for older adults, and then using that model to get things happening for a patient. So there's different ways of thinking about that. We've got paper and pencil, and someone taking that risk score and adding it up and then telling a person how they're doing and handing them some education materials. That's the lowest tech, right? And that's available, and people have been doing it. Then there's the Nutri-East screen. You need some sort of computer, of course, and a printer to print out the individualized messages. That's already available. And then you have the tablets, where those family health teams that have a bit of funding and receive that tablet, they have access to the ocean software, and it's already there. So I think there's a variety of options, and key is figuring out the process that can work for you, depending on the limits you have to work within.
Very good. Well, thank you. We've been very efficient with our time today. So thank you everyone for participating. And thanks once again, Heather, for sharing all of your expertise and depth of knowledge and experience around this topic area. We're so very fortunate to have you weigh in on the questions and offer that piece around practicality and implementation.
Great. Well, thank you. It's great.
All right. Thanks again. And everyone enjoy their Wednesday afternoons. Take care.